We would like to thank the Association for the opportunity to present our work. We have no disclosures. It is widely recognized that the risks of liver resection are directly related to the volume and synthetic function of the liver remnant. However, this volume is difficult to determine preoperatively and is widely underreported. Therefore, we and other investigators have defined a major hepatic resection by the amount of liver resected. However, no standard definition exists, as different anatomic thresholds and anywhere between resection of 2 to 6 segments have all been used to define a major hepatic resection. This inconsistency has several implications for the field of hepatobiliary surgery. These include adding to difficulties in estimating postoperative risk when counseling patients, hindering effective comparisons of postoperative outcomes between studies, and clouding the focus of those studies aimed at improving the overall safety profile of liver resection by evaluating new transection technologies and techniques. Given this background, the objective of this study was to determine the extent of resection that should define a major hepatectomy by identifying those patients at highest risk for postoperative complications after liver resection. To accomplish this objective, we conducted an IRB-approved retrospective review of all liver resections that occurred at 2 high-volume academic centers, Duke and the University of Pittsburgh, in the contemporary era between 2002 and 2009. We specifically excluded those patients who only underwent a liver biopsy or ablation as their only hepatic procedure. The number of segments resected was specified according to the Brisbane 2000 liver terminology. Specifically, a right hepatectomy and left hepatectomy were specified to include resection of 4 and 3 segments respectively. An extended right or extended left hepatectomy was defined as resection of 5 segments. A left lateral sectionectomy and a right posterior sectionectomy was specified as resection of 2 segments. For the purposes of this study, a wedge resection was defined as resection of half a segment. The total number of segments resected per patient was added and then rounded down to the nearest whole number. Study endpoints included 90-day postoperative mortality and overall postoperative morbidity. Each complication was graded according to the Clavian classification, and those complications of grade 3 or more were classified as severe postoperative morbidity. Hepatic-related postoperative complications included hyperbilirubinemia, bile leak, cholangitis, ascites, liver failure, and hepatic abscesses or fluid collections that merited intervention. Between 2002 and 2009, 1,670 patients underwent liver resection at these 2 centers. 814 or 48.7% of patients underwent resection of 2 or fewer liver segments. 219 and 637 patients respectively underwent resection of 3 or 4 or more liver segments. This slide summarizes the types of liver resection stratified by the total number of segments resected. The most common resection of 4 or more segments was a right hepatectomy, which occurred in 420 patients, or just over 25% of the entire cohort. The most common 3-segment resection was a left hepatectomy, which occurred in 167 patients, or exactly 10% of the entire cohort. A bisegmentectomy and wedge resection were the most common resections, encompassing 2 or fewer liver segments. This slide summarizes patient demographics and overall surgical treatments stratified by the total number of segments resected. Patients who underwent resection of 3 segments were older compared to those who underwent resection of 2 or fewer or 4 or more liver segments.